Hi, welcome to the channel again. Today let's talk about spot tattooing. Not when and where, but where not to. We all know the utility of spot inking. It's mainly done to identify a site of the lesion, either intraluminally at the time of a future resection or at the time of laparoscopic surgery. But there are three anatomical locations in GI tract that you should not spot ink. They are the stomach, caecum, and the rectum. These three locations are easily identifiable in any endoscopy, and in laparoscopic surgery, caecum and rectum are easy anatomical locations for the surgeons to identify. Therefore, you don't need to spot ink these three locations because there are consequences of spot inking. I would like to show you a couple of examples. Now, this one was sent to me for reassessment of a gastric polypectomy site. This is the site of the polypectomy and the spot inking, and you can see the discoloration along the greater curve there, where the spot ink has dispersed through the submucosa into most of the greater curve. Now, this makes any future resections very difficult because of the scarring that's induced by spot inking. And this is a malignant recurrent rectal polyp that was sent to me for intramuscular dissection. As you can see, there's spot inking adjacent to the polyp, and here's the lesion after marking, and you can see in the submucosal plane there is spot ink, which makes identifying the plane and dissection difficult, as demonstrated here. Not only the submucosa, as you can see here, the intermuscular plane has been infiltrated with spot ink as well, which makes it very fibrotic, therefore very difficult to dissect. Usually the intermuscular plane is easily identifiable and easily dissectable. But due to this, I had to, in a small area, do a full thickness resection, which can have consequences for the patient. As you can see, that's the site of the full thickness resection there. Therefore, I elected to close this lesion with hemostatic clips like this. Therefore, you don't need to spot ink these three locations. And in the stomach, the site of a lesion is easily describable with the location of the walls, either it's anterior, posterior, greater curve or lesser curve, and in relation to the fixed anatomical locations of pyloric channel or the gastroesophageal junction. See you next time.